Hello, and welcome to the Pediatric Pharmacy Association Core Competency. I'm Jennifer Pauley, a clinical coordinator at St. Jude Children's Research Hospital in Memphis, Tennessee, and I will be presenting on oncologic emergencies, focusing on febrile neutropenia and tumor lysis syndrome. I have no relevant financial relationships to disclose. The objectives for this presentation are to define febrile neutropenia in a pediatric oncology patient, list risk factors for development of febrile neutropenia, describe appropriate initial antimicrobial therapy for febrile neutropenia and prophylactic antimicrobials during neutropenia, explain the pathogenesis of tumor lysis syndrome, and describe the treatment options for tumor lysis syndrome. These are some abbreviations that will be used throughout the presentation. We're going to start first with febrile neutropenia. Febrile neutropenia is considered a medical emergency, and after reviewing the slides in this presentation, you will understand the importance of prompt initiation of antimicrobial therapy. But first, let's focus on a few definitions. Fever is defined as a single oral temperature greater than 38.3 degrees Celsius or a sustained temperature greater than 38 degrees Celsius over 1 hour. Axillary temperature is discouraged as it may not accurately reflect core body temperature. However, if you do use an axillary temperature for your patient, you need to add 0.6 degrees Celsius to the temperature. We try to avoid rectal temperature measurements in pediatric patients, even though it is the best measure of core body temperature. It should be avoided in oncology patients due to the risk of bleeding and infection that may be associated with it. Fever may occur in these patients for a variety of reasons. Infection may cause fever. Patients with their underlying malignancy may have a fever. But of course, you need to consider any medications that the patient may be receiving, if the patient is receiving a blood transfusion, or if the patient possibly has a venous thromboembolism. How do you define neutropenia? Neutropenia is defined as an ANC less than 500 cells per microliter, or an ANC that is expected to decrease to less than 500 cells in the next 48 hours. Patients may also have profound neutropenia, which is defined as an ANC less than 100 cells. Patients may also have prolonged neutropenia, and this is neutropenia that persists for more than 7 days. While most systems will calculate an ANC, it is important to know how to calculate it manually if it's needed. And to calculate an ANC, it is the percent SEGs plus the percent bands times the patient's white blood cell count divided by 100. So what may cause neutropenia in oncology patients? Of course, the therapy they are receiving to treat their malignancy, either chemotherapy or radiation, may cause neutropenia. The malignancy itself may cause neutropenia. Patients that have viral infections may present with decreased white blood cell counts. And of course, always considering other non-chemotherapeutic medications that may decrease the patient's white blood cell count. Examples of these include antibiotics such as sulfonamides and penicillins, anticonvulsants like carbamazepine, and antipsychotics like clozapine. So again, focusing back on why febrile neutropenia is considered a medical emergency, and this is because fever may be the only indication of an infection in an oncology patient. As many of these patients are neutropenic and don't have white blood cells, there may not be other signs of infection, such as pus or abscess, that the patients can present with. So again, thinking of the normal host compared to the neutropenic host. A normal host will present with an immune system that has the ability to fight off infections. Patients that have neutropenia have no immune system, and they therefore have the inability to fight off infections. A normal host with a fever may not require empiric antibiotics. However, again, our oncology patients that are neutropenic require empiric antibiotics within 1 hour of identification of fever. Patients that have a normal immune system have a low mortality rate if not treated with proper antibiotics initially. However, again, compared to patients that are neutropenic, there is a high mortality rate if not treated with proper antibiotics. So what is the epidemiology of febrile neutropenia? We do know that it occurs in over 80% of patients with hematologic malignancies, but only about 20 to 30% of febrile cases end up with documented infections. Of these, bacteremia occurs in 10 to 25% of patients. However, mortality is anywhere between 5 to 20% of patients if this is not addressed in a timely manner. Again, if an oncology patient presents with a fever and is neutropenic, you must treat as an infection until it's proven otherwise. How does febrile neutropenia occur in the pediatric oncology patient? As a reminder, chemotherapy affects both innate and adaptive immunity. And innate immunity allows cells to be present and ready to mobilize and fight infections. These consist of natural killer cells, dendritic cells, phagocytic leukocytes, and plasma proteins. Adaptive immunity is your memory immunity, and this occurs after exposure to a microbe. The body produces naive B and T cells to produce antibodies and effector T cells against that microbe. Organisms can be acquired through either endogenous or exogenous sources. What is the impact of febrile neutropenia on these patients? Patients that do present with febrile neutropenia may ultimately receive chemotherapy dose reductions and delays in treatment, and the emergence of resistant pathogens due to empiric and prolonged antimicrobial use always has to be considered. Immunosuppression is known to increase the risk of febrile neutropenia. Oncology patients can be immunosuppressed by using chemotherapy to treat their malignancy, radiation, the use of corticosteroids, and the use of other agents such as cyclosporin, tacrolimus, sirolimus, or everolimus. What increases the risk of febrile neutropenia in these patients? Any disruption of the patient's mucosal barrier can increase their risk of febrile neutropenia, and this can be, examples of this are mucositis, typhlitis, and colitis, and invasive procedures and devices that these patients may have. So surgery or other procedures, and any indwelling catheters such as central venous access and enteral tubes. Does the type of malignancy impact the risk of febrile neutropenia? And yes, it does increase the risk. So patients with solid tumors typically have mild immune defects, mild neutropenia, and shorter duration of neutropenia, so are therefore at slightly lower risk. Patients with hematologic malignancies typically have moderate to severe immune defects, moderate to severe neutropenia, and prolonged neutropenia, so are at higher risk. And then, of course, our hematopoietic stem cell patients that have prolonged periods of neutropenia, profound neutropenia, and long-term suppression are at maybe at our highest risk of developing febrile neutropenia. So how do these patients present, and what is the workup that is required? Again, keep in mind that any signs and symptoms of infection may be diminished because these patients don't have white blood cell counts. So the patients may be presenting only with fever as a symptom. Patients may be lethargic. They may present with upper respiratory symptoms. They may have abdominal pain. They may have subtle signs of infection such as thrush, or they may have pain and erythema at the catheter site. But again, this may be uncommon if the patients don't have white blood cell counts to mount that response to an infection at that site. When a patient presents with febrile neutropenia, you do want to do a complete assessment. You want to do a thorough history of their present illness, including the onset and what their presenting symptoms are, how long they've had fever, when and what type of chemotherapy they received recently, and has there been any use of growth factor? Is the patient receiving any antimicrobial prophylaxis currently? And has the patient had any documented prior infections? You do want to monitor the patient's vital signs and do a complete physical examination. Your workup should include a complete blood count or CBC with differential to get the ANC, a basic metabolic profile, checking their ESR and CRP, and then you want to get blood cultures. The recommendations are to obtain blood cultures from all lumens of any central venous catheters the patients may have. You want to consider obtaining peripheral blood cultures concurrent with central venous catheter cultures. It is best to obtain the cultures prior to the administration of antibiotics. However, if your patient doesn't have a central line and you're only attempting to get peripheral cultures and you're having a hard time, antibiotics should not be delayed if cultures cannot be obtained. Additional workup may be done based on how your patient presents. You may need to swab open lesions on the skin or in the mouth. If the patient is presenting with any CNS symptoms, you may need to consider a spinal tap. Respiratory examinations with a nasal wash or swab, including viral respiratory panels or monitoring sputum, it may be required. If the patient has any GI symptoms, you may need to check the stool or check the urine if the patient is presenting with the signs and symptoms of urinary tract infection. Additional imaging workup may be required based again on the signs and symptoms the patient is presenting with. You may need to consider a chest x-ray or an ultrasound or CT for typhlitis. So what is the risk for these patients that are presenting with febrile neutropenia? Again, it depends on many factors. Some patient-specific factors may include the patient's age, their malignancy, and their disease state. Again, the time and type of chemotherapy the patient has most recently received and the use of growth factors. And then anything that's very specific to how the patient is presenting. What is the height of the patient's fever? Does the patient have any chills or rigors at presentation? Is the patient hypotensive? Do they have mucositis? And what is the level of ANC or CRP that the patient is presenting with? There are numerous bacterial pathogens that the patient may present with, and you can see the list of both gram-positive and gram-negative bacteria that are common in patients with cancer. However, it is important to recall that documented infection only occurs in about 10 to 25% of patients that are presenting with febrile neutropenia. It's also important to remember that there may be non-bacterial pathogens that are causing the fever in these patients. These can include viral pathogens such as respiratory pathogens, rhinovirus, enterovirus, or human metapneumovirus, herpes, varicella, influenza, or cytomegalovirus. And these febrile episodes can occur because of fungal pathogens such as Candida, Aspergillus, or Zygomyces. So how do you treat the patient when they present with febrile neutropenia? Empiric therapy for a patient that is low risk during their course of febrile neutropenia, you may consider initial or step-down outpatient management if there is careful monitoring and follow-up. It is recommended that the first dose of antibiotic be administered in a hospital or clinic setting and the child be observed for more than 4 hours prior to discharge. You may consider oral antibiotics in this instance. However, this is considered a weak recommendation because institutions must have the infrastructure to implement safely, and readmission rates may be higher among outpatients treated with oral versus intravenous therapy, and further studies may be warranted to determine the safety of this. Of course, anyone taking care of pediatric patients knows the challenges to getting them to take oral antibiotics. One of the biggest challenges is ensuring that the medication is available as a liquid formulation and that the taste is something that the child will take. Again, this also includes cooperation of the child to be willing to take all of the doses of the antibiotic that is prescribed. If a patient has mucositis, they may have pain to their mouth or throat and may not want to swallow their medication, and patients may also present with impaired absorption. Low-risk treatment options include broad-spectrum therapy, which is often monotherapy, but you need to remember that you need to have anti-pseudomonal coverage. IV choices of antibiotics include cefepime or piperacillin-tazobactam. Oral options include levofloxacin or ciprofloxacin plus amoxicillin clavulanate. Empiric treatment for patients that are at high risk during their febrile neutropenia include broad-spectrum monotherapy with an anti-pseudomonal beta-lactam or carbapenem or a fourth-generation cephalosporin. You want to reserve addition of a second gram-negative agent or glycopeptide for patients who are clinically unstable if a resistant infection is suspected or in centers with high rates of resistant pathogens.